Hello, my name is Tiffany Shikuma, and this is my comparative analysis presentation. The country I chose was Malaysia. They're located in Southeast Asia. The population is about 33 million people. They have different languages and religions, and their wildlife is tigers, leopards, elephants, and orangutans. Malaysia is ranked 49th in the world for their healthcare system. They have programs targeting rural and low-income patients. In Asia, they're becoming one of the leading healthcare providers. Infant mortality rates have increased. They have universal healthcare for all citizens and legal residents. They're not based on national insurance programs, and they're funded through general taxation. Similar to the US having co-payments, the patients also have to pay a small fee. For a cold visit, they'll pay about $10. And if they were to stay overnight in a hospital and they want a private room, they'll pay about $50. Many healthcare packages are focused on screening and preventative health. A physical examination costs about $70, which includes a chest x-ray, full sets of blood tests, and other diagnostic procedures. Their healthcare system is divided into two sectors. The first one is government-led and funded public sector, and the second one is becoming private sector. Public sector caters to 65% of the population, and they are served by 45% of all registered doctors and fewer specialists. Most doctors are required to serve at least about 3 years in the public sector to ensure there's coverage for the population. Public health is cheaper, but private has advantages such as faster services, and there is a little difference between quality of staff or equipment between the two. As far as training and retraining programs for employers and employees are very important. They want to increase mobility and adaptability. They need to address education and training providers. They spent 11.4 billion on a project called the Malaysia Plan to implement education for training. And then when it comes to their skills, they use the National Occupational Skills Standards, which is the NOSS. Quality and patient care have become priorities nationally and internationally. Managers face challenges improving quality and safety. Determinants affecting performance are staff competency levels, leadership style, organizational cultures, and working environments. Their health outcomes are measured by their life expectancy, infant mortality, and under five mortality. Their goal is for the income level to help improve the national health status. Now, as far as the US healthcare, they do not provide universal coverage. They are defined as a mixed system. They have Medicaid and Medicare along with private health insurance plans. They intertwine relationships, so they have providers, payers, and patients receiving the care. The healthcare system is at a constant state of evolving. 50% of citizens revise private insurance through employers. 6% received private insurance through health insurance marketplaces. 20% relied on Medicaid, 14% relied on Medicare, 1% on public forms of insurance, and 9% are uninsured. Physician fees are not included with diagnostic related group, or also known as DRG. DRG is widely used in Medicaid, Medicare, and private payers. The current procedural terminology, also known as CPT codes, are used for inpatient and outpatient billing. Private insurers pay hospitals based on DRGs, case rates, and discounted fees for service. Hospitals are reimbursed less than the cost of services if the patient uses Medicaid, Medicare, or they're uninsured. This is a diagram of the flow of funds in healthcare in the US. As you can see, the left is private households and the right is providers of healthcare. Changing the ownership of healthcare providers is the evidence that innovation is where all opportunities are. Some federal and public ownership, largely by private corporations. Public sectors have declined over the years. There's little difference between for-profit and not-for-profit hospitals, and that comes in cost. Doctors undergo oral and written examinations for knowledge. And as we all know, doctors are very well paid and they also have access to most sophisticated treatments. When it comes to training for the US, there is not much support in the workforce. Training fails to lead to good jobs or boost productivity. The government is not helping, and business and workers are unable to do this alone. So a new policy needs to be put in place by the government to kind of help aid businesses and workers. Businesses usually invest in highly educated or highly paid employees. Workers have little room to budget an increase in training. Training has no guarantee of leading to a good job. The quality of healthcare in the US is standard setting. They have policy dysfunctional behavior, competition regulation, emergency planning, and they want to ensure the provision for public health, such as immunizations, vaccinations, infectious disease control, and sexual health. The infant mortality in the US is 5.547 per 1,000. The life expectancy is 76.1. The US ranks last overall in healthcare outcomes domain. The US ranks last in the mortality measure. Some high income nations get more for their health dollars. Other high income countries invest in social services, invest in primary care doctors, and they prioritize mental health. Just a reminder about this presentation, we are not comparing the two, Malaysia versus the US. Malaysia is considered to be a developing country, whereas the US is considered to be a developed country. And although a lot of people like to say the US has the best healthcare system, that is not entirely true. It does need a lot of work and it is not perfect. Here is my references page. And that will conclude my presentation. Thank you.